In this section, we're going to start talking about the beta blockers and the calcium channel blockers. We'll start with the beta blockers. So the beta blockers are indicated for hypertension, angina, congestive heart failure, selective arrhythmias, a prophylaxis of migraine headaches, MIs, acute and prophylaxis, and there's also some unlabeled uses, include mitral valve prolapse, alcohol withdrawal, nadolol for atrial fibrillation, paroxysmal supraventricular tachycardia, and ventricular tachycardia prophylaxis for hyperthyroidism. So what is the mechanism of action? The beta-2 receptors are found mainly in the heart, and stimulation from catecholamines cause an increase in heart rate, blood pressure, and myocardial contractility and AV conduction, and a decrease in AV node refractoriness. Beta-2 receptors are also present in heart muscle, but are more prominent in the lungs and in the peripheral vascular smooth muscles. Activation of the beta-2 receptors cause arterial vasodilation and bronchodilation. These are the medications we see are used often for asthma or COPD, whereas the beta-1 receptors are specific for the heart. All beta blockers have similar mechanisms of action. They are competitive blockade of the beta adrenergic receptors. This results in decreased heart rate, myocardial contractility, blood pressure, and myocardial oxygen demand. Beta blockers also reduce the metabolic myocardial stimulant, vasodilator, and bronchodilator actions of catecholamines, and they suppress the renin release. Again, there's selectivity, cardioselectivity, and pulmonary selectivity. As a result of beta blockade, cardiac output and heart rate are decreased. There's slowing of the AV conduction system, preventing an increase in cardiac automaticity and prolongs the refractory period. There's decreased sympathetic peripheral outflow that blocks the release of renin. Carlol, labetalol, and pindalol do not consistently inhibit renin release. The blood pressure is lowered by the action of beta blockers in decreasing cardiac output, peripheral vascular resistance, venous return, plasma volume, and renin release. The intrinsic symptomatic activity, or the ISA, active beta blockers do not reduce renin release. As you remember, renin, angiotensin-renin pathway can cause hypertension, and the beta blockers do not reduce the renin release. Selectivity or cardioselectivity refers to the ability of the drug to proliferate and block the beta-1 receptors. Cardioselective beta blockers will inhibit beta-1 receptors while producing less inhibition of the beta-2 receptors that mediate bronchodilation or peripheral vasodilation. However, cardioselectivity is dose-dependent, and substantial beta-2 blockade occurs in patients with angina for whom higher doses are used. Thus, the advantage of using beta-1 selectivity to reduce bronchospasms and decrease peripheral resistance may be diminished with high-dose regimens. Most providers use selective beta blockers. Cardioselectivity is a clinically important feature of these beta blockers. Intrinsic symptomatic activity, or ISA, is another characteristic of beta blockers. Also known as the partial agonist activity, ISA simultaneously blocks natural catecholamine while only partially activating beta receptors. Therefore, the side effects such as bradycardia, bronchoconstriction, and resting peripheral vascular resistance may be minimized. ISA is not beneficial for stopping arrhythmias and may eliminate the effectiveness of beta blocker in the secondary prevention of MIs. The pharmacokinetics is clinically important as well. The characteristics of beta blockers may influence their clinical usefulness and side effects. The beta blockers can be classified into two categories, those excreted by the liver and those excreted by the kidneys. Propranolol and metoprolol are lipid-soluble, are almost completely absorbed in the small intestines, and are largely metabolized by the liver. Because these agents are highly lipophilic, they readily enter the CNS and are responsible for side effects such as lethargy, confusion, sleep disturbances, and probably depression. Lipid solubility of the beta blocker is a clinical necessity with migraine headaches or tremors, or where tremors are treated. These drugs also have a highly variable bioavailability and relatively short plasma half-lives. In contrast, drugs such as atenolol and sotalol are more water-soluble and are poorly absorbed. They are eliminated unchanged by the kidney and generally do not cross the blood-brain barrier. They show less variance in bioavailability and have longer plasma half-lives. Beta blockers have adverse metabolic effects as well. This limits their usefulness, especially in patients with hypercholesterolemia and diabetes mellitus. Beta blockers can cause moderate elevation in blood sugar, increased insulin resistance, reduced HDL cholesterol, and elevated triglycerides. They also may blunt the signs and symptoms of hypoglycemia. It has been proposed that inhibition of sympathetic activity may lead to a reduction in the patient's quality of life from fatigue, depression, and a decreased exercise capacity when compared with the ACE inhibitor therapy. However, this quality of life disadvantage with beta blockers has not been confirmed in clinical trials as of yet. Selectivity or cardioselectivity refers to the ability of the drug to block the beta-1 receptors. Cardioselective beta blockers will inhibit beta-1 receptors while producing less inhibition of the beta-2 receptors that mediate bronchodilation or peripheral vasodilation. However, cardioselectivity is dose-dependent, and substantial beta-2 blockade occurs in patients with angina for whom higher doses are used. Thus, the advantage of using a beta-1 selectivity to reduce bronchospasms and decrease peripheral resistance may be diminished with high-dose regimens. Most providers use selective beta blockers. Cardioselectivity is a clinically important feature of the beta blockers. Intrinsic symptomatic activity, or ISA, is another characteristic of the beta blockers. Also known as partial agonist activity, ISA simultaneously blocks natural catecholamine while only partially activating beta receptors. Therefore, the side effects such as bradycardia, bronchoconstriction, and resting peripheral vascular resistance may be minimized. ISA is not beneficial in stopping or preventing arrhythmias and may eliminate the effectiveness of beta blocker in the secondary prevention of MIs. The competitive blockade of the beta adrenergic receptors cause a decreased heart rate, myocardial contractility, blood pressure, myocardial oxygen demand, and reduce metabolic myocardial stimulants. Is a vasodilator and bronchodilator actions, reduces the vasodilator, bronchodilator actions of catecholamine. Again, suppresses the renin release, and cardiac output and heart rate are decreased. Beta blockers relieve the symptoms of angina by competitively inhibiting sympathetic stimulation of the heart, thereby reducing both heart rate and contractility. Because beta blockers reduce the heart rate, blood pressure product during exercise, symptoms of angina or ischemic threshold during exercise are delayed or avoided. Beta blockers are also used in CHF. CHF is is caused by an active renin-angiotensin system coupled with increased tone of the sympathetic nervous system, thus decreasing the catecholamine levels, reducing cardiac congestion and left ventricular hypertrophy. Beta blockers may increase beta-1 receptor sensitivity and restore inotrophic response. Beta-2 receptors promote peripheral vasodilation, thus reducing cardiac congestion and LVH. Beta blockers again decrease the catecholamine levels, increase beta-1 receptor sensitivity, and promote peripheral vasodilation. These all cause a decrease in work of the heart. The beta blocker is used to prevent arrhythmias by blocking abnormal cardiac pacemaker potentials, thus decreasing myocardial oxygen demand, prolonging ventricular filling time, and decreasing microvascular damage of the myocardium. They prevent arrhythmias by blocking the abnormal cardiac pacemakers potentials. They also cause a decrease in myocardial oxygen demand, and the heart doesn't have to work as hard. By prolonging the ventricular filling time, more blood is pumped into the heart, and more oxygen is allowed to be used in the heart muscle. This in turn decreases that microvascular damage to the myocardium. Beta blockers are important drugs that are known to decrease mortality. However, the choice of beta blockers must be patient-specific because of the many potential side effects that limits compliance. Selection of agents should be limited to drugs with documented indications and known efficacy. You should choose only a few beta blockers and become familiar with their use. Propranolol, atenolol, metoprolol, carvedilol, and labetalol are the most commonly used beta blockers. And as you can tell, with the OLOL makes it easy to identify these as beta blockers. Beta blockers and diuretics generally have been the preferred use for initial agents because there have been documented to reduce cardiovascular morbidity and mortality in long-term controlled clinical trials. Newer studies reveal that beta blockers should not be considered a first-line drug therapy for hypertension because of the risk for development of diabetes mellitus is high. As we saw in the other sections, the diuretics are first-line drug and beta blockers after. However, many still consider beta blockers to be a good first-line medication in select patients, and beta blockers may serve as an ideal initial agents with patients who have angina, arrhythmias, compensated heart failure, post-MI status, tremors, glaucoma, and vascular headaches. Patients who should not be prescribed a beta blocker are African American patients and those with asthma or COPD, severe peripheral vascular disease, Raynaud's phenomenon, depression, bradycardia, or second or third degree heart block, as well as hypoglycemia-prone diabetic patients in whom the early warning signs of hypoglycemia may be masked. These agents also should not be used for hypertension in the elderly unless a compelling reason, such as coronary artery disease, MIs, or CHF, is evident. Beta blockers have not been shown to reduce the risk of stroke that accompanies the use of antihypertensive medications and should not be used for prevention. Beta blockers must be used with caution in patients with heart conditions such as heart block, sinus bradycardia, cardiogenic shock, or heart failure. Bradyarrhythmias, AV block, heart failure, and exacerbation of peripheral vascular disease has occurred in these patients. In diabetic patients, beta blockers may intensify hypoglycemia and prolong gluconeogenesis through inhibited release of insulin. Clinical signs and symptoms of hypoglycemia may be blocked by these drugs, and clinical signs and symptoms of thyroid toxicosis may be masked, and an abrupt withdrawal may precipitate a thyroid storm. Symptoms of depression may be aggravated in individuals with a history of depression who take beta blockers. Asthma and COPD may be exacerbated through the use of beta blockers due to their selectivity. So what do we treat, what do we use beta blockers in treatment? The beta blockers are the treatment of choice for chronic stable and unstable angina. The goals of therapy are to reduce the frequency and severity of symptoms and improve exercise capacity without producing significant side effects. The therapeutic effect of beta blockers in relieving angina is dose-dependent. Therefore, attainment of adequate blockade is important. The provider should choose among nitrates and beta blockers when selecting a first-line treatment, although many patients will be taking nitrates along with beta blockers. The beta blockers will be needed during the necessary nitrate-free time. For simplicity, many providers simply prescribe beta blockers alone. Resting heart rate and drug levels are variable and are poor predictors of control. A more precise approach to treatment involves drug titration that is based on frequency of anginal symptoms and nitrate use. The goal of therapy, again, is to reduce the frequency and severity of the symptoms and improve their exercise capacity. Secondary prevention of MI has also been found with the use of beta blockers. In 2004, the American College of Cardiology and the American Heart Association Task Force on the Management of ST Elevation in MIs recommended that all patients should receive beta blocker therapy, except those at low risk. Low-risk patients are those with normal or near normal left ventricular function, successful reperfusion, and absence of significant ventricular arrhythmias, as well as those with contraindications. Beta blockers have been shown to improve survival in patients who have had an MI, particularly in reducing the incidence of sudden death in high-risk patients. In 2012, Guides for Prevention of Cardiovascular Disease recommended that beta blocker therapy be used in all patients with left ventricular systolic dysfunction, with an EF of less than 40%, with heart failure or prior myocardial infarction, unless otherwise indicated. Use should be limited to carvedilol, metoprolol, succinate, or bisoprolol, which has been shown to reduce mortality. Early treatment of patients with MIs with beta blockers occurs during most patients' hospital stays. This approach has shown a small benefit in selected patients. Immediate beta blocker therapy may provide an additional benefit of reducing the incidence of intracerebral hemorrhage after thrombolytic therapy. Beta blockers can be also used in chronic heart failure. Patients with symptomatic heart failure have elevated levels of norepinephrine. This increase in sympathetic activity may have harmful effects, and clinical trials have shown that the blockade of beta-adrenergic receptors leads to symptomatic improvement and enhanced survival in heart failure. Beta blockers produce increased ejection fraction and reduction in left ventricular size and mass. Patients have fewer hospitalizations and less mortality, with a reduction in sudden death from congestive heart failure. Excuse me. Guidelines from the 2005 American ACC and AHA task force recommend that beta blockers should be used in patients with asymptomatic or symptomatic left ventricular dysfunction unless they are contraindicated. Patients should not receive a beta blocker. Include those with a heart rate less than 60 beats per minute, a systolic arterial pressure of less than 100 millimeters of mercury, any signs of peripheral hypoperfusion, or a PR interval of greater than 0.24 seconds, as well as second or third degree heart block, severe COPD, history of asthma, or severe peripheral vascular disease. Beta blockers with ISA should be avoided. Carvedilol, metoprolol, extended release only, and bisoprolol are administered for heart failure. The starting doses of these drugs are significantly lower than those used for hypertension, and edema caused by carvedilol can occur, although this drug is considered an effective antioxidant. Beta blockers, again, should be avoided in these patients with a heart rate less than 60 beats per minute. Often in the hospital, this will be lower. It will be less than 55 or 50 beats per minute. A systolic arterial blood pressure less than 100. However, in the hospital, again, they may lower that to 90 millimeters of mercury. And signs of peripheral hypoperfusion, as well as a PR interval of greater than 0.24 seconds, second or third degree AV block, because of the blockade effects of these drugs. They're also contraindicated with patients with severe COPD, history of asthma, and severe PVD. This is related to the beta-2 receptors. The role of beta blockers in the treatment of atrial fibrillation is unclear. Propranolol has not been shown to be effective in maintaining normal sinus rhythm after direct current electrocardioversion. However, other beta blockers such as metoprolol may provide some benefit. Sotalol is a unique beta blocker because it's classified as a class 2 and class 3 antiarrhythmic. Sotalol is a mixture of isomers and is referred to as a DL-sotalol. It has both beta blocking class 2 and cardiac action potential duration prolongation class 3 properties. In clinical studies, sotalol has been shown to be as effective as and less toxic than quinidine and as effective as propafenone, but less effective than amiodarone. Sotalol is a preferred agent in patients with a history of coronary heart disease. Thus, antiarrhythmic drugs are mainly used as primary therapy in patients who do not want or are not candidates for internal cardiac defibrillation. This may be due to comorbidities or end-stage heart failure that makes death likely. These drugs have new major indications for people with genetic predisposition for long QT syndrome. It is far more common to use antiarrhythmic drugs in conjunction with ICDs to reduce the frequency of appropriate shocks or of inappropriate shocks due to atrial arrhythmias. Although it reduces recurrent arrhythmia and the frequency of ICD shocks, sotalol is considered second-line therapy to amiodarone. Sotalol is also indicated for ventricular arrhythmias. It has been shown to prevent recurrence of sustained ventricular tachycardia or ventricular fibrillation. However, sotalol is generally less effective than an ICD. This difference is seen largely in patients with ejection fractures less than 35%. Bradycardic and proarrhythmic events can occur after initiation of sotalol treatment. Therefore, sotalol should be initiated and doses increased in a hospital setting only, where cardiac rhythms can be monitored. There is some patient variability. For example, when looking at race, African Americans should not be treated with beta blockers as first-line therapy. Reduced effectiveness in this population is likely the result of lower plasma renin levels coupled with greater circulating volume. Diuretics and calcium channel blockers are the preferred agents. In geriatrics, patients need to recognize the potential for hepatic and renal failure. Drug concentration levels accumulate quickly in the elderly with compromised systems. Thus, therapeutic doses must be small, even half the normal dose, and titrated slowly in the elderly patient. Elderly patients have described sedation and sleep disturbances associated with beta blocker use, as well as confusion, fatigue that may be profound at times. In pediatric patients, the safety and effectiveness of beta blockers, with the exception of propranolol, has not been established in children. However, atenolol, metoprolol, and labetalol have been used to treat children with hypertension. It's not FDA approved, and recommended referral to pediatric specialists is considered. For patients that are pregnant and lactating, the benefits of beta blockers in pregnancy should clearly outweigh the risks. Low birth weight infants have been reported in mothers who use beta blockers during pregnancy. The categories vary among the different beta blocker medications. For example, ace-butylol is a category B, whereas bisoprolol during the second and third trimester, metoprolol, nadolol, and propranolol are considered category Cs. Atenolol is considered category D. Beta blockers do appear in the breast milk. Either breastfeeding or the drug should be discontinued. For patient education, you need to stress to the patient that they need to report shortness of breath, nocturnal cough, or lower extremity edema. They should not discontinue the medication abruptly. It needs to be slowly discontinued. They should report use of beta blockers to their ophthalmologists and dentists due to the constriction of the vessels. They should monitor pulse and contact healthcare providers if their heart rate is lower than 50 beats per minute. Diabetic patients need to be cautious that beta blockers can mask the signs of hypoglycemia, and patients should use caution when performing hazardous tasks due to the CNS side effects. In many patients, exercise-induced fatigue may develop, and although patients should eat healthy foods and increase exercise, these medications do not always allow them to increase their level of exercise, and this may prevent them from taking the medication. Warnings and precautions. Again, beta blockers do cause hypotension, especially in the elderly. Patients need to be forewarned of this, make position changes slowly. They need to be aware that Use of other drugs such as calcium channel blockers can lead to heart block due to the blockade effects of these medications, and these medications should be avoided in patients with bronchospastic diseases such as asthma and COPD that is severe. Abrupt withdrawal of the medication can lead to a withdrawal symptom and exacerbation of angina, MIs, ventricular arrhythmias, and death. Again, remind patients that this medication may mask the signs and symptoms of hypoglycemia as well as hyperthyroidism. This may result in masking thyroid storm, which can be life-threatening. Beta blockers may also alter the lipid profile, and adverse effects include bradycardia, depression, impotence, GI effects, fatigue, weakness, and insomnia. So now we'll move on to the calcium channel blockers. These medications are indicated for hypertension, vasospastic angina, arrhythmias, and off-label uses such as stable angina and Raynaud's syndrome. The calcium channel blockers are indicated for a variety of cardiovascular conditions and are categorized into 3 subclasses. Only one class, the dihydropyridines, include more than one commercially available drug. The main difference between these medications and the other classes is that these medications do not affect the cardiac conduction system. Cardizem is generally considered to have effects that are more similar to those of verapamil than those of nifedipine. All drugs in this class are available in generic formulation. The short-acting nifedipine should not be used for acute reduction in blood pressure, in control of essential hypertension, immediately after an MI, and in acute coronary artery syndrome, as well as 36 hours prior to surgery. So what is the mechanism of action? These medications block inward movement of calcium through the slow channels of cell membranes, thus their name, calcium channel blockers. They result in negative inotrophic effects as well as negative chronotrophic effects, decreased cardiac output, afterload reduction, and they inhibit coronary artery spasm. There are 3 types of tissue cells acted on, are as follows. Although these compounds have diverse chemical structures, they all share a basic electrophysiologic property. They block the inward movement of calcium through the slow channels of the cell membranes, mostly of cardiac and smooth muscle cells. The drugs differ in their location of action, such as the cardiac muscle or the myocardium, the cardiac conduction system, both the SA and AV nodes, and vascular smooth muscles. These include the coronary arteries and arterioles, as well as peripheral arterioles. Calcium channel blockers decrease the force of myocardial contraction by blocking the inward flow of calcium ions through the slow channels of the cell membrane during phase 2, the plateau phase of the action potential. The diminished entry of calcium ions into the cells thereby fails to trigger the release of large amounts of calcium from the sarcoplasmic reticulum within the cell. This free calcium is needed for excitation, contraction, coupling, the event that activates contraction by allowing cross bridges to form between the actin and the myosin filaments of the muscles. The number of actin and myosin cross bridges formed within the sacromere determines the force of the heart's contraction. Decreasing the amount of calcium ions released from the sarcoplasmic reticulum causes fewer actin and myosin cross bridges to be formed, thus decreasing the force of contraction and resulting in a negative inotrophic effect. This decreased cardiac this in turn decreases cardiac output. In these tissues, calcium channel blockers decrease automaticity in the SA node and decrease conduction in the AV node. Automaticity means that the cells depolarize spontaneously and initiates an action potential without an external stimuli. It is a normal characteristic of the SA node cells. Depolarization, or phase 0 of the action potential, is normally generated by this inward calcium ion current through those slow channels. Thus, the agents that can block the inward calcium ion current across the cell membrane, especially of the SA nodal tissue, decreases the rate of depolarization and depresses automaticity. The result is a variable decrease in heart rate, negative chronotrophic effect. Similarly, an agent that decreases calcium ion influx across the cell membrane of the AV node slows the AV nodal conduction, resulting in a negative chronotrophic effect and prolongs AV refractory time. When AV conduction is prolonged, fewer atrial impulses reach the ventricles, thus slowing the rate of ventricular contractions. The smooth muscle of the coronary artery and peripheral vessels have a significant influence on afterload and the hemodynamics of circulation. The decreased force of smooth muscle contraction results in coronary artery dilatation, and this lowers coronary resistance and improves blood flow through collateral vessels as well as oxygen delivery to ischemic areas of the heart. Calcium channel blockers dilate the main coronary arteries and arterioles in both normal and ischemic regions. Therefore, drugs with these actions are helpful in the treatment of angina pectoris. Calcium channel blockers reduce arterial pressure at rest and at given levels of exercise by dilating peripheral arterioles and reducing the total peripheral resistance or afterload against which the heart works. This results in reduced blood pressure. This unloading of the heart reduces myocardial energy consumption and oxygen requirements and probably accounts for the effectiveness of calcium channel blockers in chronic stable angina and causes a decrease in blood pressure. Calcium channel blockers are also potent inhibitors of coronary artery spasms. This property increases myocardial oxygen delivery in patients with coronary artery spasm and is responsible for the effectiveness of calcium channel blockers in vasospastic angina. Nifedipine is an example. It is a potent dilator of vascular smooth muscle and causes decreased peripheral vascular resistance in both coronary arteries and peripheral arterioles. Nifedipine has a mild negative inotropic effect, less than that of a verapamil, and usually a small increase in heart rate occurs along with a reflex response to vasodilatation. Nifedipine has no tendency to prolong AV conduction or prolong SA node recovery time or slow the sinus rate. Verapamil also dilates vascular smooth muscle, although it's less potent than nifedipine. Verapamil has a significant negative inotropic effect that prevents and blocks reflex tachycardia and relieves coronary artery spasms. The negative inotropic effect decreases myocardial oxygen demand and thus helps to relieve angina-related ischemia and pain. Verapamil also slows conduction in the SA and AV nodes, although it has a greater effect on the AV nodes. Diltiazem, or other name is cardizem, has a less negative inotropic effect than verapamil and causes less peripheral vasodilation than nifedipine. Diltiazem selectively has more effect on cardiac muscle than on peripheral vascular smooth muscle. It slows conduction through the SA and AV nodes, but not to the extent that verapamil does. So treatment principles. The peripheral vasodilation caused by nifedipine and these related drugs often makes them more effective for hypertension than verapamil and diltiazem, but more likely to cause peripheral edema. Peripheral edema, namely pedal edema, results from selective dilution of resistance vessels without concurrent venodilation. An overall increase in proximal capillary pressure drives the increased formation of extravascular fluid and results in pedal edema. Nifedipine and related drugs are seen to have no effect on cardiac conduction and therefore do not cause arrhythmias, nor do they treat them. Verapamil and diltiazem have significant effects on cardiac conduction and are used to treat arrhythmias in addition to hypertension. They are less likely to cause hypotension than nifedipine and related drugs when used to treat angina in patients who do not have hypertension. However, they are more likely to cause conduction problems than nifedipine and related drugs when used to treat hypertension. They should be used cautiously with beta blockers, if at all, because beta blockers also affect conduction. Calcium channel blockers are not generally recommended for the treatment of heart failure. These agents have not been shown to improve exercise tolerance, quality of life, or survival. The ACC-AHA update did not recommend this use of this class in heart failure. Calcium channel blockers are the treatment of choice in variant or Prinzmetal's angina. The dihydropyridines, verapamil, diltiazem, and the nitrates are all effective as first-line therapy choices. Both classes of drugs reduce vasoconstriction and promote vasodilatation in the coronary arteries. However, dosing is generally patient-specific. Nitrates and beta blockers still remain first-line therapy for chronic stable angina, but calcium channel blockers are the treatment of choice, again, for the variant Prinzmetal's angina. In chronic stable angina, calcium channel blockers are effective in relieving symptoms and increasing exercise tolerance in formal exercise testing. These drugs reduce coronary vascular resistance, increase coronary blood flow, and decrease myocardial oxygen demand. They also reduce ST segment changes on ambulatory electrocardiographic monitoring, and the 2002 ACC-AHA guideline update for the management of patients with chronic stable angina recommended that nitrates and beta blockers should remain first-line therapy. Calcium channel blockers are reserved for patients with contraindications or adverse reactions to beta blockers or nitrates, and for those whose symptoms are not well controlled with a combination of these agents. Among the available agents, long-acting diltiazem or verapamil or a dihydropyridine such as amlodipine or felodipine should be used. For hypertension, the thiazide-type diuretics are recommended as first-line consideration for most patients with hypertension without compelling indications. Calcium channel blockers do not produce hyperlipidemia or insulin resistance as diuretics do, and they do not cause sedation, drowsiness, or sexual dysfunction as the beta blockers do. Calcium channel blockers reduce peripheral vascular resistance without stimulating reactive renal and hormonal responses. Calcium channel blockers also increase sodium excretion moderately, and in contrast to most other antihypertensive agents, their effectiveness is not significantly improved by dietary salt restrictions. Calcium channel blockers are safe and effective for a wide variety of hypertensive patients. African Americans, the elderly, and patients with hyperlipidemia are considered good candidates for calcium channel blockers. Treatment with calcium channel blockers or diuretics given as monotherapy to African American patients has proved to be more effective versus some other classes of antihypertensions in terms of degree of blood pressure reduction. These drugs may be preferred in patients taking nonsteroidal anti-inflammatories because they can increase blood pressure moderately by reducing the production of prostaglandins, which are vasodilating substances. The efficacy of calcium channel blockers is not blunted by the use of nonsteroidal anti-inflammatory drugs, and overall calcium channel blockers are met with good patient acceptance because of their low incidence of adverse reactions. So for monitoring patients, the patients, you should obtain and monitor serum digoxin levels if calcium channel blockers are initiated in patients on digoxin. You follow weekly or biweekly while dosages are being titrated upward. Once stable, you should monitor the patient periodically every 3 to 6 months for any adverse response and control of the disease process. Again, obtain and monitor serum digoxin levels if calcium channel blockers are initiated in patients receiving digoxin, and kidney and liver function tests should be performed periodically. The patient should be informed not to take calcium channel blockers with grapefruit juice. This is known to affect the liver cytochrome P450 enzymes and to interfere with the drug metabolism. For geriatric patients, lower dosages of calcium channel blockers should be used because older patients are more susceptible to their side effects such as the dizziness, weakness, orthostatic hypotension, syncopal episodes, and falls. However, calcium channel blockers generally are well tolerated and often the drug of choice for elderly patients. In pediatric patients, the safety and effectiveness of calcium channel blockers in children have not been established. However, increasing experience with long-acting calcium channel blockers such as nifedipine, amlodipine, and felodipine in children with essential hypertension has shown to be safe and effective. For those patients that are pregnant or lactating, the calcium channel blockers are considered category C. Teratogenic and embryotoxic effects have been demonstrated in small animals. Verapamil, diltiazem, and nifedipine are excreted in the breast milk, and it is not known whether other drugs are excreted in the breast milk as well. For race, considerations. Again, the calcium channel blockers are more effective in African American patients and are considered the drug of choice. For patient education, you need to advise the patients that they may experience hypotensive effects during dose titration and should be cautious when changing position during the initial dose titration. You should urge your patients to report any signs of congestive heart failure, such as swelling of the feet, shortness of breath, irregular heartbeats, nausea, constipation, dizziness, or hypotension. Nitrate therapy while patients are on calcium channel blockers may cause some dizziness. Consider staggering the times medications are taken to minimize this effect. If taking extended release tablets, patients may pass inert shells in the feces, and this is especially true with Procardia XL. And again, patients should not take calcium channel blockers with grapefruit juice. It's known to affect the liver cytochrome P450 enzyme system and to interfere with drug metabolism. This interaction is most common with the dihydropyridine calcium channel blockers, specifically nifedipine and felodipine. The calcium channel blockers that exhibit the greatest interactions in this group are the ones that are poorly absorbed and have low bioavailability. Grapefruit juice inhibits CYP450 metabolism of calcium channel blockers in the intestinal wall. Therefore, absorption is greatly enhanced and results in a greater pharmacological effect. For example, nisolapine and amlodipine are dihydropyridines with very low and very high bioavailability, respectively. Absorption of nisolapine was increased more than fourfold versus only slightly increased in patients taking amlodipine. The magnitude of the interaction is highly variable between individuals, but reproducible as well. Therefore, the implications for patients involve significant blood pressure reduction or minimal blood pressure reduction. Again, caution should be used with the elderly, especially those who have problems with hypotension.